So esophagus, it is a, you have read the esophagus in parts, cervical parts, thoracic part, like this. Okay. So and also histology you have learned esophagus. Okay, so we will learn this all together. Esophagus is important short note for your theory. Okay. So esophagus is a mucomuscular tube connects the pharynx with the stomach. Okay, and it has three parts: cervical part, thoracic part, and the abdominal part. And these are the measurements of the esophagus. Length is about 10 inches or 25 centimeter. Width is about 2 centimeter and its lumen is normally closed and opens only during the passage of the food. Okay, so that's why we have seen during the mediastinum dissection in the posterior mediastinum, we have seen esophagus as a flattened muscular tube. Okay, and this length is important for your viva and MCQ, length of the esophagus. These parts are also asked in your viva. What are the different parts? Cervical, thoracic, and abdominal part of the esophagus. Next, what is the course of esophagus? It begins as continuation of the pharynx at lower border of the cricoid cartilage, and it passes downward in front of the vertebra through the superior and posterior mediastinum of the thorax. Okay. Here, this lower part is visible. This is esophagus. It is lying posterior to all these structures. So it passes downward in front of the vertebra through superior and posterior mediastinum of the thorax, pierces the diaphragm opposite to the T10 vertebra. Okay, through the esophageal opening of the diaphragm, and finally opens at the cardiac end of the stomach at the level of T11 vertebra. Okay, so this is these vertebral levels are important, where it pierces the diaphragm and where it enters the stomach. See here, this is esophagus, starts at the lower end of the pharynx and ends at the cardiac end of the stomach. And it has these three parts. This is cervical part, 4 centimeter. This is thoracic part, about, this is the longest, 20 centimeter, lying in the superior and posterior mediastinum. And this is abdominal part after entering through the esophageal opening of the diaphragm, and it is about 1 to 2 centimeter. Okay, and there are constrictions of the esophagus. Constrictions are very, very important. Constriction individually can come in your theory, okay, and also can be asked in your viva. First constriction is lying at pharyngoesophageal junction. Second, where it is crossed by the arch of aorta. Third one, at the crossing of the left principal bronchus. This is trachea is dividing into two bronchi. Third one at the crossing of left principal bronchus, and fourth one at the passage through the diaphragm. Okay, so these are the four constriction present in the esophagus, and the distance of this constriction from the incisor teeth is this. So, and this distance is important for passage of the laryngoscope. Okay, for passage of the uh, um, laryngoscope. So distance from the upper incisor teeth is about 15 centimeter. Second constriction, it is about 23 centimeter, and this third one is about 28 centimeter, and fourth one is at the level of 40 centimeter. Okay, so there is high chance of obstruction to this scope at these levels of the constrictions. That's why the distance you have to remember. So esophagus has two types of curvatures: anteroposterior curvatures and lateral curvatures. Lateral curvatures are side to side curvatures. Anteroposterior curvatures first correspond to the curvature of the cervical vertebra. In the upper part corresponds to curvature of cervical vertebra, and where the second corresponds to curvature of the thoracic vertebra. And lateral curvatures, it deviates 2 times towards the left. First at the root of the neck and second at the level of T7 vertebra. So these are the lateral curvature and it deviates to the left at these two levels. You have seen esophageal impressions over the lung, mediastinal surface of the lung, where you have seen esophageal impression. On the left side, two impression are in the upper part and in the lower part, and on the right side, one single impression. Okay, posterior to the lung root. So these impressions are formed due to these curvatures, side to side curvature of the esophagus. Next, we are going to constriction in details. So, second narrowest part of the digestive tube is the vermiform. So, esophagus is the second narrowest part, and first narrowest is the vermiform appendix of the intestine. And usually, esophagus shows 4 constrictions. First is at the pharyngoesophageal junction, that is 15 centimeter or 6 inches from the incisor teeth, produced by the cricopharyngeus part of the inferior constrictor muscle of the pharynx. Okay. Second constriction at the crossing of arch of aorta, here 23 semi or 9 inches from the incisor teeth. Third constriction at the crossing of left principal bronchus, that is 28 centimeter or 11 inches from the incisor teeth. And fourth constriction at passage through the diaphragm, here fourth constriction, which is about 40 semi or 15 inches from the incisor teeth. So these are the 4 constrictions of the esophagus. Constriction you must prepare as a short note. Okay. So this is chart you remember. First is pharyngoesophageal junction, 15 semi or 6 inches from incisor teeth. Vertebral level is C6. Second, at the crossing of arch of aorta, distance from upper incisor is 23 semi or 9 inch. Vertebral level is T4. And third is at crossing of left principal bronchus, 28 centimeter or 11 inches. T6 vertebral level, and fourth is lying at T10 vertebral level at the passage through the diaphragm through esophageal opening, and it is about 40 centimeter or 15 inches from the upper incisor. Okay, next we are going to relations of the cervical part of esophagus. Anteriorly lies the trachea and recurrent laryngeal nerves. Okay, these are lying at tracheoesophageal groups. Next, posteriorly lies the longus colli muscle attached to the anterior surface of the vertebral bodies, prevertebral fossa and cervical vertebra. So these are the posterior relations. And on each side there are common carotid artery, lobes of the thyroid gland and thoracic duct on the left side. So these are the relations of cervical part of the esophagus. In this part is the cervical part. On the two sides, these are the recurrent laryngeal nerves will be there. Okay, here right recurrent laryngeal, left recurrent laryngeal. On the two sides, carotid arteries. Anteriorly, posterior relation is the cervical vertebra, prevertebral fossa, and those. And anteriorly lies this trachea, thyroid gland, these parts. Okay, so these are the different relations of the and thoracic duct on the left side. Relations of the cervical part of the esophagus. Okay. Next, relations of the thoracic part of the esophagus. This you have seen in the picture. Cervical part is 4 centimeter, thoracic is 20 centimeter, abdominal part is 1 to 2 centimeter. Anterior to the thoracic part lies the trachea, arch of aorta, right pulmonary artery, left principal bronchus, pericardium with left atrium, and the diaphragm. These are lying in anterior relation to the thoracic part of the esophagus. Posterior relations. Okay, this is esophagus. All these structures are lying posterior to the esophagus. There is vertebral column here. This is the vertebral column. Right posterior intercostal arteries. These are the right posterior intercostal arteries. azygous vein with terminal part of the hemiazygous and accessory hemiazygous veins. This is azygous vein, hemiazygous vein, thoracic duct, here is the thoracic duct, and descending thoracic aorta. This is descending thoracic aorta. So all these structures are lying in posterior relation to the thoracic part of esophagus. This diagram is important. You practice the schematic diagram for this. Okay. Next to the right lies the right lung and pleura. Azygous vein on the right side, azygous vein. Here will be the right lung and pleura and right vagus nerve. And to the left, in the superior mediastinum, lies the arch of aorta, left subclavian artery, left recurrent laryngeal nerve, thoracic duct, left lung and pleura. And posterior mediastinum, here lies the descending thoracic aorta, left lung and pleura. Okay. In both cases, left lung and pleura is common, rest are changing. Okay. Superior mediastinum, arch of aorta, here is descending aorta, and rest here will be thoracic duct, left recurrent laryngeal nerve, left subclavian artery. Okay. Next, we are going to histology in short. Okay. You have read the histology already for esophagus, and in the previous day you have seen the slides also. Okay. So esophagus has 4 layers. First is from inside outward we are discussing. First is mucosa. Mucosa consists of stratified squamous non-keratinized epithelium, and it has a lamina propria and muscularis mucosa is thick. Longitudinal smooth muscles are present in the muscularis mucosa. Next, there is submucosa. Submucosa consists of dense irregular connective tissue with elastic fibers and compound tubulo-alveolar glands. So this is submucosa. Next is muscularis externa. This forms the this lies in the upper third of the esophagus, has skeletal muscle fibers in the middle third, both skeletal and smooth muscle fibers, and whereas in the lower third only smooth muscle fibers. Okay, upper third only skeletal muscle fibers, middle third both skeletal and smooth, and lower third only smooth muscle fibers are present. Okay, and then outermost is the adventitia surrounded by connective tissue layer. Only lowest 1 inch is surrounded by the serosa. Lowest around 1 inch means the esophageal part, abdominal part of the esophagus. It is covered by the peritoneum, so it is called serosa. See, like this you will see under the microscope. This is low power view, you have seen like this. So this is mucosa. Mucosa is characteristic of the esophagus, stratified squamous non-keratinized epithelium. After that, this light pink area is the lamina propria, and this is muscularis mucosa. It is very thick in the esophagus. This is also important for identification. And this part is the submucosa, consists of loose areolar connective tissue containing some glands or adipose tissues. And then there is muscularis externa, formed of 3 differences in 3 thirds. Okay, so inner circular and outer longitudinal layers are there, and outermost is the adventitia. Okay, so these are the 4 layers of the esophagus. And this is enlarged view of the stratified squamous non-keratinized epithelium. Cells are lying in multiple layers. Shapes of the cells are changing from columnar to flattened up to the surface. Okay, and multiple layers of cells are there. You can see the violet dots nucleus in multiple layers. And this is lamina propria, loose connective tissue layer, and this is muscularis mucosa, only longitudinal fibers are present. Okay, so this is only the mucosa portion. So esophagus mucosa is stratified squamous non-keratinized epithelium, lamina propria, muscularis mucosa, only longitudinal smooth muscles are present. So in the submucosa, there is dense irregular connective tissue, elastic fibers, elastic fibers are forming the longitudinal folds, and so that's why there is star-shaped lumen. and compound tubulo-alveolar glands are present in this submucosa. Okay. Next is muscularis externa, upper third skeletal muscle, middle third both skeletal and smooth, lower third smooth muscles. And adventitia or serosa, it is connective tissue layer, lower 1 inch of esophagus has the serosa. Okay. Next, we are going to clinical aspects. These clinical aspects are individually comes as a short note. Clinical aspects of esophagus are very important. Okay, so understand this carefully. So esophageal varices. Okay, these are dilated, tortuous, submucosal veins in the lower part of the esophagus, and it is caused due to portal hypertension. How it is formed? Increased portal venous pressure cause shunting of blood from portal vein tributaries to the systemic veins or vena cava tributaries. In the lower part of esophagus, there is anastomosis between these veins. Portal venous part is the left gastric vein and esophageal veins. Esophageal veins are going to drain into azygous vein and finally going to drain into superior vena cava. Okay. And what will be the symptoms of esophageal varices? There will be bleeding in vomiting, hematemesis. Okay, blood during vomiting because of the rupture of these veins. In during passage, when veins are very much dilated, lumen will be narrow. So during passage of the food, there will be rupture of the varices and there will be blood vomiting. Okay, fresh blood will come out, not digested blood. In as ulcer, in gastric ulcer or duodenal ulcer, then you will see digested blood will come out. The blackish clotted blood. But in variceal bleeding, fresh blood will come out during the vomiting. That's how you differentiate. Okay. And also in piles, in hemorrhoids, fresh blood will come out during the defecation. And in ulcer or in this ulcer or in esophageal varices rupture, there will be clotted blood or digested blood is come out through the during defecation. That is called melena. Okay. So that's how you differentiate from the symptoms of the patient. Next, we are going to arterial supply. Arterial supply of cervical part of esophagus is supplied by inferior thyroid artery, and thoracic part of esophagus supplied by esophageal branches of aorta. Abdominal part of esophagus is supplied by left gastric and left phrenic arteries. Nerve supply is by the sympathetic fibers from T5 to T9 spinal segment, and they are vasomotor and sensory. And parasympathetic fibers from the recurrent laryngeal nerve and vagus nerves. They are motor and secretomotor for the glands. Lymphatic drainage, cervical part is drained by jugulo-omohyoid lymph nodes, thoracic part into pre-paratracheal and posterior mediastinal nodes, and abdominal part is drained into left gastric and celiac lymph nodes. So these are the lymphatic drainage of esophagus. Okay, and this is venous drainage. See, there is a venous plexus formation between the veins on the two sides. Azygous system of veins. Azygous vein in lower part accessory hemiazygous, in the upper part accessory hemiazygous, and here is the hemiazygous. Through this venous plexus, it drains into the superior vena cava. Okay. And nerve supply, sympathetic fibers are coming from T5 to T9 spinal segments. See here, these are the nerves. These are the sympathetic chains. They are supplying the esophagus from these roots. T5 to T9 spinal segments, and they are vasomotor and sensory. And parasympathetic fibers are coming from the recurrent laryngeal nerve and vagus. See, these are the recurrent laryngeal nerve and these are the vagus. They are supplying the parasympathetic supply, and they are motor and secretomotor for the esophageal glands. Next clinical aspect is referred pain of esophagus, or it represents heartburn. Esophageal pain is carried by sympathetic fibers or T4 and T5 segment. Esophagitis is inflammation of the esophagus, occurs in gastroesophageal reflux disease. Okay, food is passing backward through the gastroesophageal sphincter, and pain of the esophagitis is felt in the region of chest wall, supplied by the T4 and T5 spinal nerves, lower thoracic and epigastric region. Pain is felt. Okay, this is the region where heart is lying, lower thoracic and epigastric region. In cardiac pain is also felt in this region. So this esophageal pain is also referred to this region because of the common nerve supply, common route of nerve supply, and may be difficult to differentiate esophageal pain from anginal pain. Next is esophagoscopy. Esophagoscopy is visualization of interior of the esophagus using the esophagoscope. Okay. And dysphagia. Dysphagia is difficulty in swallowing. Esophagus, during passage of the esophagoscope, you have to remember those distance from the incisor teeth. Okay, distance of these four constrictions. Next is dysphagia. Dysphagia is difficulty in swallowing. May occur due to esophageal compression from external structures or narrowing or stricture of the esophageal lumen. See here, this is esophagoscopy, passage of the endoscope through the mouth, and this is incisor teeth. From here, the distance is measured. Okay, at different constriction. It is passing through the oral cavity, oropharynx, laryngopharynx, then esophagus, and gradually into the stomach. Okay, and at the tip of the endoscope, there is a light is present for visualization of the lumen. Okay. Next is Achalasia Cardia. This is very important. These two clinical aspect is very important. Comes in your short note. Esophageal Varices comes in your short note, and referred pain of esophagus comes in your viva and important for your clinics. And these two are important short note for theory. Achalasia Cardia and Tracheoesophageal Fistula. Okay. Achalasia Cardia is failure of relaxation of lower esophageal sphincter due to congenital absence of ganglion cells in the myenteric plexus of the esophageal valve. Causes accumulation of food in the esophagus, and radiological examination in barium swallow x-ray, you will see bird's beak or rat tail appearance of the esophagus. Okay, lower end is constricted, that will appear as a rat tail. And tracheoesophageal fistula, it is most common congenital anomaly of the esophagus, abnormal congenital communication between the trachea and esophagus due to failure of development of laryngotracheal septum. Okay. See, this is in Achalasia Cardia. This is rat tail appearance or bird beak appearance in barium swallow X-ray of the esophagus. Okay, lower part is constricted. Here the barium is appearing as tail of the rat. Okay, so this is normal esophagus. There is with the dilatation in the upper part, widening of the esophagus due to blockage in this region, and non-relaxing lower esophageal sphincter as due to absence of ganglion cells in myenteric plexus. Okay, Achalasia Cardia. This is very commonly given X-ray in your final year Achalasia Cardia. Okay, and this is tracheoesophageal fistula, abnormal development of the laryngotracheal septum. See, proximal segment of esophagus has a blind end and distal segment is connected to the trachea here. Okay, so there will be no passage of food. You have to do surgical collection. Surgical correction, you have to cut it from here and have to connect it with this proximal segment for proper passage of the food. Okay. Okay. So esophageal atresia with distal segment communicates with the trachea in 90% of cases. There are different variations are there. In 90% cases, this occurs. Okay, proximal segment is blunted and distal segment is connected with the esophagus. Trachea. Okay, so you read it from your embryology book, from the development of trachea and esophagus, that part you read for this. Okay, so this is tracheoesophageal fistula. Next is carcinoma of the lower third of the esophagus. It occurs mostly in the lower part of esophagus and produces difficulty in swallowing. Okay, carcinoma. Next is Barrett's esophagus. This also comes in your short note. Barrett's esophagus. Okay, lining epithelium of esophagus changes from stratified squamous to simple columnar epithelium with goblet cells. And main cause of Barrett's esophagus is GERD, gastroesophageal reflux disease. And this is a precancerous condition, Barrett's esophagus, changing of the epithelium. This is a precancerous condition. It will develop into carcinoma later on. So this is summarization of the esophagus. It is a mucomuscular tube. Individually, esophagus can come as a short note in your theory. You have to write down these parts in 2 to 3 lines: measurements, course, curvatures, constrictions, blood supply, and complete it. And some clinical aspect if you can write. So measurement is length is 25 semi, width 2 semi, lumen normally closed, opens for passage of the food, and course it is continuation of pharynx at the lower border of cricoid cartilage and pierces the diaphragm at T10, opens at stomach at T11. Two types of curvatures are there, anterior-posterior and two left lateral curvatures. Anterior-posterior at the cervical level, one is thoracic level. 4 constrictions are there at pharyngoesophageal junction, crossing of arch of aorta, crossing of left bronchus and passes through the diaphragm. This is the narrowest. This passes through the diaphragm. Okay. Blood supply, arteries and veins. Arteries are inferior thyroid artery, esophageal branches of aorta, left gastric and phrenic arteries. These are the arteries. Veins are the inferior thyroid vein, azygous vein, hemiazygous vein, and left gastric veins. Okay. And these are the clinical aspects. Esophageal varices are dilated tortuous veins formed due to portal hypertension, referred vein of esophagus, esophagoscopy, dysphagia, Achalasia Cardia, and Tracheoesophageal Fistula. All we have discussed previously. Histology of esophagus comes in your short note or spotter slide, and constrictions of esophagus comes individual short note. Okay, and those clinical aspects are important. Portal hypertension, esophageal varices, Achalasia Cardia, Tracheoesophageal Fistula, all those are important short notes. Okay, understood?